Hello, I'm Dr. Allison Fiducia, the co-founder of Psychedelic Support, and we're quite excited to have a very special topic today in our monthly speaker series. And really, we hear quite a lot about set and setting as related to psychedelics and how that can impact the experience. There's so much emphasis put on the mindset or how someone is feeling whenever they enter into an altered state of consciousness. And often there's a lot less emphasis placed on what is going on in the brain and body, which can entail certain medications someone might be on or medications that were recently discontinued. So in this talk, Psychedelics and Psychotropics, Drug Interactions and Clinical Approaches, we're going to be exploring how these different types of medications might interact with the psychedelic experience. And we have an expert here, Dr. Ben Malcolm, aka the Spirit Pharmacist, who has earned his master's in public health and a doctorate in pharmacy at Touro University in California. And after doing a residency training, he obtained a board certification in psychiatric pharmacy. His interest on the intersection between psychiatric medications and psychedelic therapies. And currently he provides psychopharmacology consulting services for clients and continuing education on psychedelics and medication interactions. He has some awesome resources available on his website, The Spirit Pharmacist, which I'm putting in the chat here for you. And at the end of the talk, we will give you a copy of these slides. We also will put out the video in an email and on our YouTube channel, so you can watch this again or share it with your colleagues. So we'll probably have some questions, time for Q&A at the end. And as we're going here, I'm going to try to enable the chat because I really do like for you all to be able to share what brought you here, who you are, and any kind of conversations you want to have along the way. So give me a minute and hopefully I can get that activated. But I'm going to turn it over to you, Dr. Malcolm, and thank you so much for being here and taking the time to present to us.
Thank you so much for having me. It's a real pleasure, and I never want to miss an opportunity to talk about psychedelics and drug interactions. I'm going to kind of have this talk broken into 4 different sections. I'm first just going to kind of introduce drug interactions and what drug interactions are. Not everyone in the audience may be familiar with that. And then the 2 psychedelics I'm really going to focus on as far as drug interactions are MDMA and Psilocybin. And I'm going to base those sections off of a systematic review that I published along with some colleagues earlier this year, particularly Dr. Sarkbras. He was the first author and did a lot of work on that article. So a lot of the information in this talk is actually going to be from that systematic review of drug interactions. And we covered drug interactions between psychiatric medications and specifically MDMA or psilocybin. I'm going to talk about the pharmacology of those 2 substances as well, because I think that drug interactions are relatively logical and predictable. And if you understand the kind of kinetics or metabolism, as well as the mechanism of action of drugs, then it allows you to probably have a pretty solid guess at what kinds of substances might interact with psychedelics, and I think allows for just a deeper level of understanding about drug interactions in general. And then I'm going to finish by talking about approaches, or essentially some approaches that I take in my consulting practice to the management of drug interactions when persons are curious or planning psychedelic experiences. Okay, so let's start with our introduction here. And before I specifically talk about drug interaction, there's these sort of 2 overarching and broad areas of pharmacology known as pharmacokinetics or pharmacodynamics. And it's a little bit simplified. There's more to pharmacokinetics than what the human body does to the drug. There's things like I would say like routes of administration and absorption, things like that. But a lot of what we're talking about with pharmacokinetics, at least when it comes to drug interactions, has to do with the body's ability to metabolize drugs. And oftentimes drugs will compete for metabolic enzymes, or there might be one drug that actually blocks that metabolic enzyme and interferes with the metabolism of another. There's lots of different factors that can influence pharmacokinetics, like age, end organ function, nutritional status, illness, genetics, and some other things as well. As far as pharmacodynamics, you're usually thinking about, the action of the drug in its intended sort of tissue, and what you're like thinking the action or mechanism of the drug is. And oftentimes there are drugs that have some type of overlap in their mechanisms. They might target the same things, or they may target disparate things, but part of the same nervous system. And that's a lot of what we're talking about today, is the serotonergic nervous system and interaction with serotonergic psychedelics. So drug interactions can be sort of pharmacokinetic or metabolically related in nature. There are some other pharmacokinetic interactions, protein or like albumin binding, and then they can be pharmacodynamic, or sort of like overlapping in mechanisms of actions. And subdrugs interact on both levels, and that's actually true for many of the SSRIs that block CYP2D6 at a metabolic level. So there's a pharmacokinetic interaction with psychedelics, but they also work on the serotonin reuptake pump. So there's a pharmacodynamic type of interaction to consider as well. So sometimes it gets quite complex as more than one type or way of interaction occurs. So when we're talking about drug interactions, there's DDIs, or drug-drug interactions, and I sort of introduced pharmacodynamic and kinetic interactions on the previous slide. I'll say when it comes to like metabolism or transport-related interactions, if you block liver enzymes or CYP enzymes that are involved with metabolizing drugs, that results in increased concentrations of the drug requiring that metabolic enzyme. But you can also have drugs that act to upregulate the production of metabolic enzymes. They call this CYP induction, and it can actually result in lower concentrations of drugs that are metabolized by the enzyme, because the population of enzyme has actually increased. And I'll say that that's also true about pharmacodynamic interactions, in the sense that you can have pharmacodynamic interactions where things are kind of additive, like 1 + 1 = 2, synergistic, like 1 + 1 = 4 or 5, or maybe diminutive, 1 + 1 = 1, 1 + 1 = a half, or perhaps even nothing if they're completely canceled each other out. And then this last one, I think for the audience, like as a pharmacist, right, I get asked about drug interactions or drug-drug interactions, and I will say that overall, we don't have a lot of information, but at the same time, there's probably relatively few drugs that actually clinically significantly interact with different types of psychedelics. But oftentimes I'm asked about, well, what about this blood thinner and psychedelics? And it's like, well, I don't really think, or I can't really predict much in the way of a drug-drug interaction between blood thinners and psychedelics. But if a person is taking a blood thinner, that means they have some kind of advanced cardiovascular condition. They're probably being treated for some type of clot or maybe arrhythmia, and those conditions have been excluded from clinical trials. So anytime a person is taking a medication, you view that as a surrogate marker for an illness. And a lot of the time, it's not necessarily about drug-drug interactions, and wondering about, well, okay, they're taking these medications for what kinds of illnesses, and what are the severities of those illnesses? And do those illnesses present contraindications, or perhaps just some increase in risk that needs a mitigation strategy? So I think this is like a big sort of like thing that I want to hammer here, is that a lot of the time it's a drug disease type of interaction, and it's not necessarily a drug-drug interaction. Okay, so this table here, table 4 that you see on this slide, is from our systematic review of drug interactions with MDMA and psilocybin. And I included it because it shows different psychiatric medications by class, and then summarizes the randomized controlled trials that have been done with either MDMA or psilocybin and different types of psychiatric medications. what you notice is that overall, there's relatively few drug-drug interaction studies available. And it appears that there's been more drug-drug interaction studies done with MDMA compared to psilocybin. And this is probably because MDMA has a more complex mechanism of action. It releases serotonin, dopamine, and norepinephrine. So there's been a lab or two that have really been looking at the mechanism of action of MDMA and kind of systematically testing it. Well, what about an SSRI? What about a dopamine norepinephrine reuptake inhibitor? And they've kind of systematically used different pharmacologic probes to test the mechanism of MDMA. And it's actually through this kind of like line of research that I think that we've kind of arrived at a consensus that the lion's share of MDMA's mechanism is through release of serotonin. Whereas with psilocybin, you see that the drug-drug interaction studies that are done are sort of clustered around drugs that interact with the serotonin 2A receptor. So you see things like ergotamine or buspirone, which are agonists or partial agonists at the serotonin 2A receptor, and then atypical antipsychotics like risperidone or chlorpromazine that are antagonists or maybe inverse agonists at the serotonin 2A receptor. So a lot of the drug-drug interaction focus, at least in medical research with psilocybin, is really focused on interactions at the serotonin 2A receptor. But there was one recent trial done with an SSRI, escitalopram or Lexapro, that I'll talk a little bit more about later in the presentation. So the data is pretty scarce overall, but what really is apparent from what we have so far is that there is clinically significant drug-drug interactions between psychiatric meds and these psychedelics, and that these types of interactions are probably going to, or definitely going to have large consequences for the potential safety or efficacy of psychedelic therapies. And our host, Ali Fiducia, has this review article that was authored with Price and colleagues, where they really did a nice job about kind of laying out, well, this is a sort of a conundrum for like patient education, counseling, and really makes us scratch our heads and thinks about like, well, okay, the first line treatments, if they diminish effects of psychedelics, should they be first line treatments, and or should we be really counseling patients that are beginning those first line treatments that they may be limiting or potentially making it more difficult to use other options that are beneficial for refractory types of illnesses. So this is really a big deal, the drug interactions between these first-line psychotropic medications and psychedelics, because it can affect outcomes and safety for people. So who are the players, right, at the serotonin synapse? You have some abbreviations here, or common medications that are used at the serotonin synapse, and you will see that if you're talking about at least kind of classic tryptamine psychedelics, or maybe the ergoline LSD, they work by binding serotonin 2A receptors. There's also some psychiatric medications that bind serotonin 2A receptors and stimulate them. I mentioned buspirone as well as ergotamine on the previous slide, but you also have SGAs, or second generation or atypical antipsychotics, block this receptor, as well as mirtazapine and trazodone. So there's a number of drugs that directly interact with the serotonin 2A receptor that can or potentially diminish effects of psychedelics. You have drugs that block the serotonin reuptake pump, like SSRIs or SNRIs, some tricyclic antidepressants, and there's some newer type of SSRI medications, the SPARIs, the serotonin partial agonists and reuptake inhibitors. So they're kind of hybridizing mechanism of like buspirone, like a serotonin receptor partial agonist with a reuptake inhibitor for those. Those are like Trintellix or vortioxetine. MDMA works to release serotonin. I'll go into a little bit more depth about that, but it works on packaging proteins as well as the reuptake pump. And then there's MAOIs, which block monoamine oxidase. So these kind of classes or drugs are probably some of the biggest or major suspects when it comes to thinking about clinically significant drug-drug interactions with either MDMA or psilocybin. And there's kind of two pieces to this, and it seems that both pieces have some credibility to them or hold some weight, in that there's potential for direct drug-drug interactions. Like if you're taking buspirone and it's binding to the serotonin 2A receptor, psilocybin probably can't bind that receptor as well, and you just get a diminished effect due to a direct competitive drug-drug interaction. They're competing for that receptor, or competing to bind at that receptor. But many of these psychotropic medications, and particularly the SSRIs or SNRIs, have been well studied in this regard, produce neuroadaptive effects over longer periods of time. So there was a paper that came out, I don't know, a few months ago that was like the serotonin hypothesis of depression is wrong. You know, SSRIs, they boost serotonin, and you know, higher serotonin doesn't necessarily mean less depression. And it's kind of like, well, we've actually known that for a very long time, because you block the serotonin reuptake pump and you get increased amounts of serotonin, but it's not until weeks later that the person actually starts feeling better. So it highly suggests some type of genetic neuroadaptive event that actually makes a person feel better, rather than just increased serotonin, a person feels better. Because if that were true, a person would feel better almost immediately after taking an SSRI. So unfortunately, it appears that these longer term neuroadaptive interactions involve either downregulation of the serotonin reuptake pump or downregulation of serotonin receptors themselves. So you can get what they call like a decreased density of postsynaptic receptors. So essentially, there may be less receptor available for a psychedelic to act if a person has been taking one of these serotonin reuptake blocking medications for a long period of time. And we're not exactly sure the time frame it would take for this sort of neuroadaptive event to reverse. My reverse logic would be that if it takes 2 to 6 weeks for the full therapeutic effect of an SSRI to occur, then it might take 2 to 6 weeks for the changes to reverse upon discontinuation, but that's speculation. Monoamine oxidase inhibitors are dangerous with MDMA, and I'll cover the reasons for that a little bit more in a slide or two. Okay, let's talk about MDMA. So MDMA primarily releases serotonin, but it can also bind serotonin receptors itself. So in this diagram, you see MDMA as the red molecules and serotonin as the blue molecules. And typically, the serotonin reuptake pump takes serotonin from the synapse and takes it back into the presynaptic nerve terminal. But under the influence of MDMA, the flow of neurotransmitter reverses. You get what they call carrier-mediated release of serotonin. And this carrier-mediated release of serotonin results in increased intrasynaptic serotonin. So you do get more serotonin in the synapse with MDMA. And this probably informs risks of things like overdose or risks of serotonin toxicity, because to get serotonin toxicity, you need to have increased intrasynaptic serotonin. So it's like one feature of MDMA, because it increases intrasynaptic serotonin, serotonin toxicity is possible, particularly in overdose settings or in combination with other drugs that increase intrasynaptic serotonin, like monoamine oxidase inhibitors. MDMA is able to bind serotonin 2A receptors itself, but it does this fairly weakly compared to, say, psilocybin or LSD. So MAOIs are potentially lethal with MDMA, yet SSRIs appear to diminish responses. Why? If you can answer that question now, then you're done with this talk. You're good. But if not, pay attention, and I'll get to it in a slide or two. The metabolism of MDMA is mostly hepatic, and the primary metabolic enzyme is cytochrome CYP2D6. But MDMA is an autoinhibitor at CYP2D6. So even if you are a poor metabolizer at CYP2D6 pharmacogenetically, you will have higher concentrations of MDMA. The experience kind of might hit you harder or faster perhaps than some other people. But because MDMA itself blocks CYP2D6, it seems that the differences that you see between CYP2D6 poor metabolizers and extensive metabolizers aren't so massive, because the drug itself renders a person a poor metabolizer through CYP2D6 inhibition. There have been reports of persons having severe toxicity or even death with a couple of HIV antiretroviral types of medications that are almost like pan-CYP inhibitors, meaning that they block not only CYP2D6, but a number of the other CYP liver enzymes that you see listed on this slide. And there's also drugs like Wellbutrin that blocks CYP2D6 as well as CYP2B6 that definitely increases the blood concentrations and duration of an MDMA experience, and probably also do things like increase risks of seizures. So there are some pharmacokinetic interactions with MDMA that are clinically significant and avoid either changing regimens, holding doses, or just avoiding MDMA use in the case of those HIV medications. If a person was doing well with management of their HIV, I probably wouldn't stop or change it to use MDMA. I'd pick a different psychedelic. So this is MDMA and antidepressants. These are the drug-drug interaction trials that have been done. They're fairly small trials, 8 to 16 people. They are healthy volunteers, so they usually give the antidepressants for a few days to maybe a week, but not a long period of time. And they test it in combination with MDMA, and then they switch and do antidepressant, or I should say placebo and MDMA. So what you sort of notice across the board is if it's an antidepressant that blocks the serotonin reuptake pump, then it really significantly diminishes the effects of MDMA. They've tested 3 SSRIs, 1 SNRI, and the result has been fairly consistent across all 4 of these little trials, in that the results are, decreased somewhat, and 60, 70, 80%. I mean, you're not getting very much of an experience at that point. It's kind of like you take some MDMA and maybe it feels like you had a strong espresso or something like that, but there's really not much of the characteristic effects of MDMA present. Depending on the antidepressant, you also saw it blunt some of the physiological parameters of use, but you did see some of the antidepressants producing higher blood concentrations of MDMA. So what's the deal there? Well, these types of antidepressants are CYP2D6 inhibitors. So through a pharmacokinetic interaction, you get higher blood concentrations of MDMA, but through a pharmacodynamic interaction, it seems that the overall effect of combining them is a more diminished or muted kind of experience. I mentioned Wellbutrin on the kinetic side previously, but it's here again. And we saw 10 to 30% increases in MDMA concentrations, a longer duration of an MDMA experience, and higher blood concentrations of MDMA. Vice versa too, MDMA, because it blocks CYP2D6, increased concentrations of Wellbutrin in that trial. Okay, so here's your answer. Why do SSRIs mute the effects of MDMA, whereas MAOIs are dangerous? And it really kind of comes down to, well, these 3 classes of drugs, MDMA boosts serotonin, SSRIs boost serotonin, and MAOIs boost serotonin. So they're kind of the 3 classes of drugs that when you combine them, you might be more worried about an increased risk of serotonin toxicity. But with the case of MDMA and SSRIs, it's really unclear if that's true, and probably if it is true, then you might need to take really, really, really big doses of MDMA to make it happen. Because this is what occurs. You take your MDMA and it tries to release serotonin like it normally would, but you've got an SSRI or SNRI blocking the serotonin reuptake pump. And you've got monoamine oxidase here in the presynaptic terminal that's free to just chew it up and metabolize it. So the SSRIs or SNRIs directly block MDMA's primary mechanism, which is to release serotonin, and what you observe are relatively muted sort of effects. So makes sense to me. Whereas if you block monoamine oxidase, well, now MDMA is releasing serotonin and increasing intrasynaptic serotonin like it should, but that serotonin has nowhere to go and nowhere to be metabolized because monoamine oxidase is blocked. And so you get excessive amounts of intrasynaptic serotonin and potential for life-threatening types of serotonin toxicities. This is from our systematic review. This is a table of other drugs that interacted with MDMA. There's not a ton of really significant findings to report, or findings that, I don't know, would at least make me feel like that's a contraindication or they would need to stop that kind of medication, at least outside those antidepressants that I've already kind of covered. I do apologize, like things like subjective experience. We have some really nice tables in the systematic review that tell you exactly what scale was used and which parameters of that scale was affected. I just didn't have that space on the slide, and I figure that's why we made the reviews to give you the details. I guess I will say with MDMA though, that things like clonidine, right? Carvedilol. So there's been like a couple like sympatholytic types of agents like beta blockers or alpha-2 agonists that have been tested, and they did not have any effect on the subjective experience, but they did lower blood pressure and heart rate. So they lowered cardiovascular responses of MDMA. And my thoughts is sort of like, oh, as a clinician, I'm kind of thinking like, well, geez, if I had someone with maybe some type of cardiovascular condition that might make you think MDMA is high risk, potentially using a sympatholytic could maybe mitigate some of that risk. No data, no trials around that, but it's just sort of a thought that is like, okay, well, if I wanted to reduce the cardiovascular responses of MDMA without messing up someone's subjective experience, and perhaps they had a prescription for one of these, they'd taken them before and they tolerated it well, could be reasonable. Okay, so this is our summary of drug interactions with MDMA. I think I've kind of talked about a lot of them. A few that I haven't that I'll point out is lithium. Lithium is not a small molecule, it's a chemical element on the periodic table of elements. It's also used as a pharmaceutical, and it seems to change intrasynaptic, or I should say intracellular, not intrasynaptic, serotonin signaling in a way that increases risks of either just a poor experience, like a negative quality of experience, or seizures. So lithium I consider contraindicated with MDMA or psilocybin. Benzodiazepines, we do not have any randomized trials about effects of benzodiazepines on serotonergic psychedelics, but it seems fairly well known or out there that benzodiazepines mute or reduce the effects of psychedelics like MDMA or psilocybin. You can find lots of people talking in anecdotal forums about benzodiazepines being the trip killer or like the trip abortant type of thing. If you review, like hallucinogen research guidelines, they'll talk about, okay, well, first line for, agitation is like emotional support, but, situations, persons are agitated, hurting themselves, threatening other people, things like that. A benzodiazepine becomes the drug of choice to use. So it seems like it's well recognized, even in hallucinogen research guidelines, that you can reduce the effects of psychedelics using benzodiazepines, but we're lacking any kind of formal data there. And then I just think MDMA is a stimulant, so adding other stimulants probably increases risks of stimulant toxicities. And I think I've talked about the kinetics. On to psilocybin. So relative to MDMA, psilocybin actually has a pretty simple mechanism of action. All right, excuse me. A simple mechanism of action. So it binds postsynaptic serotonin receptors, but it doesn't have any kind of clinically significant effect on monoamine oxidase, the serotonin reuptake pump, or VMAP, the vesicular packaging protein. All right, it's like I choked on the water. So psilocybin binds serotonin receptors. It doesn't fully bind them, though. It's what they call a partial agonist. So it has a ceiling as far as the amount of serotonergic response it can cause by binding that receptor. And it's incapable of increasing intrasynaptic serotonin. So when people are thinking, can I get serotonin toxicity from eating mushrooms? My answer is no, you can't, because to get serotonin toxicity, you have to have drugs that increase levels of intrasynaptic serotonin, and I've not been able to find anything that would make me conclude psilocin or psilocybin is capable of that. And then the other part of it is like, well, it's a partial agonist at serotonin receptors, so no matter how much you take of it, you could probably only get a partial serotonergic response physiologically. And when I kind of think about, is there a lethally defined dose of psilocin? Pretty hard to find that kind of information. And do people directly die of psilocin toxicities? It's like, again, it's hard to find that information. Do people have intense psychological experiences and get in unsafe environments and maybe inflict harm upon themselves because they're in a deep psychedelic type of state or something like that? Yeah, that's possible, but it's not a direct physical toxicity from psilocybin or psilocin. So overall, it's a mechanistically simpler type of drug than MDMA, and probably has less risks of drug interaction, probably has less risks of toxicity, particularly in overdose types of settings, or maybe in combination with other substances. So why am I talking about psilocin when everyone talks about, so it's like a mechanism of psilocybin, I've got psilocin here at serotonin 2A synapses. So yes, it's psilocybin that you actually ingest in mushrooms, but it's a prodrug. It is dephosphorylated to psilocin, which is probably the active molecule of psilocybin mushrooms, because your subjective effect of mushrooms maps a lot more closely to psilocin blood concentrations than it does to psilocybin blood concentrations. Psilocin is mostly metabolized by glucuronidation, which means adding a sugar molecule, glucose being sugar, glucuronidation. So this is not a sort of phase 1 or CYP type of metabolism where a lot of the pharmacokinetic or metabolic drug-drug interactions occur. This is a strategy that the liver uses to make drugs more water soluble so they can be eliminated by the kidney. And there may be some substances that can block these glucuronal transferase enzymes, but we don't have any kind of formal information about them. And on the whole, it seems that metabolic drug interactions with psilocybin are less likely than other psychedelics, and particularly like CYP metabolized psychedelics like MDMA. Some part of psilocin is metabolized by monoamine oxidase. I've seen different estimates, maybe around 20% of psilocin is metabolized by monoamine oxidase. It seems that compared to unsubstituted tryptamines like NN-DMT or 5 substituted tryptamines like serotonin or 5-MeO-DMT, that the 4 substituted position makes it less likely to be metabolized by monoamine oxidase or creates some kind of what they call like a steric hindrance, which makes it more difficult for monoamine oxidase to bind with psilocin and metabolize it, but still some MAO metabolism. Skip a slide? No. Okay, so less information to talk about with psilocybin compared to MDMA. And what we have observed is that buspirone tended to lower the effects of psilocybin. Seems like ergotamine, it was pretty weak. Like it lowered some effects, it raised some effects, but we're all talking sort of the 10 to 20% range, where I think it's difficult to tell if there's anything appreciable going on. Some of these experiments are quite old, right? Chlorpromazine, I think this one's from the 60s. So they're just talking about major or minor visual responses, which may not be too informative. But then you see things like diminished physiological effects too, like not as much pupil dilation. Risperidone is an atypical antipsychotic that did decrease the effects of psilocybin, and they observed some dose dependent reductions in a delayed response task as well. Risperidone was actually engineered to be a blocker of LSD in rodent drug discrimination assays. So a lot of the times when people say antipsychotic, particularly atypical antipsychotic, in the case of risperidone, it's actually kind of synonymous with anti-psychedelic because it was engineered or designed to block the effects of LSD in rodents. So it doesn't surprise me that it reduces the effects of psychedelics like psilocybin in persons. Haloperidol, this is an interesting one. This is an atypical antipsychotic. It doesn't bind serotonin receptors. It does block dopamine receptors. And it seems like with either MDMA or psilocybin, you still got psychedelic effects, but they weren't necessarily very good psychedelic effects. It seems like it increases the risks of things like anxious ego dissolution. So instead of having a sort of mystical type of ego dissolving effect, having a very anxiety or dysphoric type of ego dissolution effect. And this one at the bottom, our only study of SSRIs in combination with psilocybin. Interesting study. They treated people with escitalopram for 2 weeks in the study, which I think is sort of a flaw. Like I think you would really want to treat people for at least 4 weeks and maybe more like 6 to 8 weeks before testing it with psilocybin, particularly if you really wanted to answer the question, is there a drug-drug interaction with psilocybin in persons that are truly taking SSRIs for therapeutic purposes? And it kind of seems like in the abstract, like if you read the abstract of the article, that there wasn't very many effects that were diminished, or it actually negated some of the negative aspects of the psilocybin experience. And it almost feels like there's some narrative that SSRIs reduce the bad effects of psilocybin, but preserve some of the mystical effects. And I think I want to challenge that a little bit in that, yes, you do see any drug effect was decreased, particularly bad drug effects, right? Anxiety was way down, 80% less anxiety, but ineffability was also down 19-20%. And you also saw some of the physiological parameters get blunted, the same way that you saw them get blunted with SSRIs or SNRIs and MDMA, where almost definitively the effects are much diminished. And there's a difference, right? With MDMA, it's much more direct because it blocks the serotonin reuptake pump. With psilocybin, it's indirect because psilocybin is binding the serotonin 2A receptor. So the interaction between SSRIs and psilocybin is probably more of those long-term or neuroadaptive or genetic adaptation types of interactions than it is like an acute competitive thing, which kind of means to me that we don't really know the answer to this question yet. But based upon this study, it seems like, well, some effects of psilocybin are definitely diminished. And although they observed mostly reductions in bad or anxiety types of effects, they did notice some decreases in more mystical things like the ineffability of the experience as well. So again, psilocybin and lithium, seizures, poor quality of experience, consider it contraindicated. Serotonin receptor blocking antipsychotics, serotonin agonists like buspirone and the reuptake blocking antidepressants likely diminish effects of psilocybin, or at least diminish some of the effects of psilocybin. Same deal with benzodiazepines, trip killers, abortin types of medications, reduce effects of psychedelics, probably in a dose and temporally dependent manner, right? So you've got somebody that's taking 0.5 milligram of lorazepam once a week. Is that going to kill their experience? They took it 5 days ago. No, it's not, right? You got someone that's taking 1 milligram of Klonopin 3 times a day. Is that going to affect their experience? Oh, probably, almost definitely. And there's maybe some need to think about tapering, holding, rearranging benzodiazepines. MAOIs are really interesting with psilocybin. It appears that if you just take an MAOI like one time, like for example, harmala alkaloids in ayahuasca, it boosts the effects of psilocybin. You can find people talking about pharmahuasca combining Syrian rue seeds or the harmalas from ayahuasca vine with psilocybin and getting intensified psychological effects. You can also find some older literature about persons that are chronically taking pharmaceutical MAOIs, and it seems they have lowered responses to psychedelics like psilocybin or DMT. So it's probably kind of a similar boat of the SSRIs in that if you take MAOIs long term, you get downregulation of postsynaptic receptors and blunted effects. Whereas if you just take an MAOI once or twice, maybe over a couple of days, you block MAO, but there hasn't been these neuroadaptive effects that have occurred yet. So you actually get increased or intensified type of psychological experiences. There's some migraine medications like the triptan migraine medications that can cause some vasoconstriction and have really rarely been associated with things like coronary vasospasm in and of themselves. There are some trials planned of psilocybin for things like migraine or cluster headaches. And in those trials, they have sort of set it up so that you shouldn't use your abortive migraine medication within 5 half-lives of ingesting the drug. It's about 12 hours. And kind of similarly on the backside, like 5 half-lives of the psychedelic, which for psilocybin is also fairly close to 12 hours. So not serotonin toxicity, not like we know that this is a very bad kind of combination, but there is some thought that there is increased risk of vasoconstriction and possible adverse outcomes associated with that. Then there's a few drugs here that listed that do have effects on those glucuronidase transferase enzymes. We're lacking any data to know if there's a clinically significant drug interaction or not. Okay. Ooh, I got to pick up the pace here. So psychedelics and psychiatric medications, I think that hopefully I've made the case that a lot of them can diminish or at least modulate the effects of psychedelics. I haven't talked too much. I mean, I talked about lithium, monoamine oxidase inhibitors, or maybe your kind of HIV medication like ritonavir or cabisistat with MDMA. But when I think of like really kind of potentially dangerous physiological drug-drug interactions with psychedelics, I'm mostly thinking about ayahuasca or ibogaine. But there are some with MDMA or lithium, perhaps with psilocybin. At this point in time, we don't really have data to inform optimal decision-making about what to do because we don't really know how much these experiences are diminished or the timelines for restoring effects and things like that. So I personally just try to use best practices for medication tapering and shared decision-making. I'm trying to figure out what does the person want to do and is that feasible and reasonable, right? Because if I can come up with a plan where the person wants to do it and it seems reasonable, then I feel like that plan is going to have a lot higher chance of success than something they don't want to do or something that I don't think is reasonable. So I think can you combine your antidepressant with psilocybin mushrooms? I don't know. My answer at this point in time is yes, you can, but you may get diminished responses. You may get changed responses. Maybe it's a poor quality of experience. Maybe there's more unpleasant somatic things like nausea or anxiety that could come up. Seems like the data supports less anxiety, but a lot of people I talk to seem to have unpleasant somatic experiences when combining antidepressants with psilocybin. And I'm not sure if this has to do with something about the antidepressant or just maybe where they're at with their mental health and position in life overall. But it seems that a lot of the time when they're starting, they're either not getting much or what they're getting is not the mystical effects that they're reading about in the newspaper. So tapering presents a lot of risks and sort of challenges to it. you can almost expect an exacerbation of symptoms or withdrawal effects. A lot of the times, the most difficult step in a taper is someone going from some medication to no medication. And due to these sort of neuroadaptive effects of particularly the serotonin reuptake blocking antidepressants, washout periods of at least a couple weeks is probably necessary. And we may find that it's more ideal to wait 4 to 6 weeks because that's the time frame it takes to kind of reestablish a similar postsynaptic receptor density of serotonin receptors compared to baseline. So how are they going to be supported in this kind of process? And, how are we going to avoid medication misadventures from detracting the safety or benefit of psychedelic therapies? And what's the correct risk benefit balance between the length of a washout period and effects of psychedelics? It's sort of like, well, if I wait 2 weeks, I restore 70% of the effects. Wait 3 weeks, 75, 4 weeks, 78. Like where is it that we should just start for the person because they're experiencing symptoms? Maybe they have some level of withdrawal despite a slow and careful taper rate, and they want to get better already. They could get 70% of an experience 2 weeks later, or 80% of an experience 3 weeks later. Should we wait that extra week or not? It's really sort of unclear at this point in time. So when I'm talking with people, these are a lot of the types of questions that I ask them or want to walk through with them. So I'm trying to figure out what are the benefits and side effects of their current drug regimen. Do they like the medications they're taking? Do they experience side effects from them? What's the goals regarding their medication? And is it realistic? You'll meet some people that have very realistic goals regarding their medication and some people that it's sort of unrealistic. What's your goals? Oh, I really like to get off all of these 4 drugs I've been taking for the last 10 years in the next month so I can use MDMA. It's like, well, that sounds like really scary and unrealistic, right? Versus, I'm taking an antidepressant. I've been taking it for a few years. I've tried to taper in the past. It hasn't gone so well, but I've always cut the dose in half. This time I'm, planning 3 or 4 months, and I'm going to go much slower. And, I'm curious about psychedelics at some point in there. Okay, sounds a lot more reasonable. What's the compatibility between their current meds and the psychedelic substance of interest? And, I'm trying to poke around, what will happen to them if they try to taper their medication? So have they tried to stop in the past? What happened? Have they missed doses before? Maybe they've gone out of town for the long weekend. They couldn't get a prescription refilled at the pharmacy. A lot of people have these things kind of happen to them and can kind of tell you a little bit more about, well, what happens if I stop for a few days or try to reduce my dose in the past. Then, ultimately kind of what are the balances and what are the risks and benefits? What's the balance of stopping or continuing the medication? Tapering is ideally done with the oversight of the prescribing provider. Some people don't have a provider. Usually encourage them to try to find one, or they're transitioning between providers, and not everyone has a provider. And a lot of antidepressants are through, I say, primary care, and primary care doctors may not feel comfortable or have much of an ability to provide a lot of oversight for a taper sometimes. So tapering aims to discontinue a drug, whereas holding aims to suspend the use of a drug temporarily. I think medications with slightly lower risks of withdrawal or lower risks for drug interactions could be held for short times around psychedelic experiences. It could restore some of the effects, could minimize risks of drug-drug interactions. In some ways, it could give the experience itself a little bit more reverence. It's sort of okay, you're making these changes in your life ahead of time. You won't go into withdrawal for skipping your medications for a day or two. Well, there's not necessarily much in the way of a strong, significant clinical reaction that could be, or interaction that could be predicted. Oftentimes the person may still just want to skip their meds for the day off. Obviously, that's medication dependent. Drugs can usually be resumed 24 to 72 hours after psychedelic use. This is based upon an indication for use, and whether they want to continue using it or not, or potentially, well, a person may be feeling well after a psychedelic experience, but if they sort of know that, well, I missed my medication for 2 days, but I missed it for 4 days, then I go into a pretty nasty type of withdrawal state, then they're probably going to want to resume that medication and not wait until they're in that nasty withdrawal state. So there are clinically significant drug interactions between first-line psychiatric meds and psychedelic therapies. The interactions can pose major hurdles or increased risks of psychedelic therapies. Further understanding of these interactions and careful management is likely critical to safe and beneficial experiences. And I haven't seen it yet, right? But, well, I guess I have seen it, but I just haven't seen it like publicized in a clinical trial of people kind of, I'm just going to stop to use psychedelics. And maybe they are able to successfully abruptly discontinue their meds and they have a psychedelic experience, but then the weeks to months afterwards are just awful for them, right? Whereas like truly their goals are to use psychedelics as an alternative. It's not really like you're going to stop taking one day and start taking the other the next day. I think that people ask me all the time, do psychedelics help taper psychiatric medications? And I don't know what the answer is, but my response is that you should think of them as two parallel processes. I'm going to do a slow and careful taper of my psychiatric med if my goal is to stop it and it feels reasonable to stop it. Okay, there's nothing that's going to replace that. There's no dose of mushroom or other supplement or stack of things that you're going to take that's just going to negate the need for that kind of taper or length of time. But you can try other things. You can do other interventions, particularly if they're compatible during the time that you're tapering, and that might help you with the process. But you probably shouldn't be viewing it that I'm doing this because it's directly going to cause me to taper off my meds without any kind of withdrawal and I'll just sail off into the sunset. Lots of people thinking that, and I think we really need to temper our expectations and do some heavy counseling on people about the types of medications they're taking and potential for changing psychedelic experience, and really having serious conversations about tapering, which I think is sort of, there was no need to taper before psychedelic therapies because there was no other sort of like alternative. But now that we have an alternative that works well, maybe even works in a superior manner to the first line agents, they directly sort of conflict or seem like they do with MDMA and they seem like they do with psilocybin. This is like a whole new world of, persons are going to need some type of program or assistance in transitioning between modalities in a safe way, because that gap between psychiatric meds and starting psychedelics, probably has a lot of room for misadventure in it. So I'm going to take some questions now, but if you like this talk and you kind of want to go deeper with some of the resources that I have some links here on the slide. So I have an antidepressant psychedelic drug interaction and tapering guide. I just released this. It's a new course, Breakthrough Psychedelics, but you can download the course reader for free. It's Breakthrough Psychedelics at a Glance. And the course is actually accredited for CE credits for therapists and related licenses. And then I have a free webinar on my website, Navigating Psychedelics and Psychotropics. Quite a bit of overlap with this talk, but also some novelty or different slides here and there. That's all I have, though. It's been a real pleasure speaking with you, and happy to let Allie lead some question and answer now.
Sure, this was excellent. So much information you gave here. And just want to make people aware, we did post the slides and we'll email them out to you along with these other great resources. I always refer to Ben's materials because they're just very clear and on point with the research. We did get quite a few questions. So I'm going to try to maybe group a few of these together. And as I mentioned in the chat, we're going to write a blog summary of this talk. And perhaps we can address some of the questions that we don't actually get to, because there's so many medications out there and people can be on all kinds of things that might potentially interact. But a few of the ones that came through was, can you speak a little bit more about interactions with mood stabilizers, in particular with psilocybin or MDMA?
Yeah, so like the mood stabilizer lithium, right? We talked about as being contraindicated with either MDMA or psilocybin. Lithium's compatible with ketamine though. Ketamine has been studied in persons with bipolar conditions with depression and shown good benefits. So if you got a person with bipolar depression taking lithium, ketamine quickly sort of becomes the lowest hanging fruit that's immediately available and accessible to them. There's not really much information about a lot of the other mood stabilizers out there. There's lamotrigine or Lamictal, oftentimes used in bipolar 2 types of conditions. It's more of an atypical antidepressant than it really is a mood stabilizer, because it doesn't have much in the way of treating or preventing mania. But lamotrigine really seems fairly compatible with serotonergic psychedelics, and there's some kind of controversial information that it could diminish the effects of ketamine. But as far as serotonergic psychedelics, I can consider lamotrigine to be compatible. There's things like, I'll say like valproic acid or Depakote, carbamazepine, oxcarbazepine. These medications have very little information about them with psychedelics. I can't really find much in the way of like anecdotal forum talk that would suggest that the effects are really muted. I'll say that carbamazepine has a lot of drug-drug interaction potential to it. I'll say like carbamazepine and oxcarbazepine also have sort of like side effects or adverse effects associated with like hyponatremia or low sodiums. I believe they can cause like SIADH. MDMA can release ADH and cause low sodium sometimes. I don't really know if it's sort of like there's a risk of additive hyponatremia, low sodiums, or seizure risks, but that's kind of where my mind, I guess, is wandering with that one.
Nice.
Yeah, I mean, there are also anti-epileptics too, right? Like those types of medications. So I think of them as like, well, anti-epileptics almost universally have like sedation or CNS depression as sort of like part of their profile. And I do think like the sort of GABAergic sedatives like benzodiazepines are probably the ones that really diminish the effects of psychedelics. But I do sometimes think that if persons are just taking a lot of sedative medication, then it's a little bit harder to get a psychedelic sparkle. But there's very little information about mood stabilizers and drug interactions with psychedelics. And, given that mood stabilizers are primarily going to be used for conditions like seizures, epilepsy, or bipolar conditions, you also really have to think about the drug disease interaction, or sort of who is this person and is their illness appropriate for psychedelics?
Great, thank you. You hit a lot of the drug names that were dropped in the chat. And the next question I want to get to is, we talked a little bit about this diminished experience with people that have recently tapered off of SSRIs, or maybe taking SSRIs concurrently with psilocybin. Is there any evidence or any thoughts about if someone could potentially increase the dose of psilocybin or increase the dose of MDMA to overcome any of the diminished effects that have been observed?
Yeah, so data, not that I've seen, persons that are doing it and I hear about it. Yeah. My thoughts on that in general is that if you take a small dose of psilocybin with your antidepressant and find that there is some level of effect, okay, then maybe you are tempted to try to take a dose that would have a full effect, right? And I think that psilocybin is probably a better drug candidate for this, because it's the kind of drug that doesn't necessarily have that lethally defined dose, or persons can get away with 5 or 10-fold overdoses of mushrooms and my God, could it be psychologically too intense? Yes. Like a psychological overdose, absolutely. But a physical overdose, they still necessarily wouldn't be doing anything that's incredibly dangerous. Whereas MDMA, it's like, okay, well, the serotonergic effects seems like they're diminished, but there's a kinetic interaction with a lot of them that boosts concentrations of MDMA. And even if it blocks some of the serotonergic effects of MDMA, if it's an SSRI, it shouldn't block the norepinephrine or dopaminergic effects of MDMA. And MDMA is just the kind of drug that you can get in serious physical hot water taking a 3 or 5-fold sort of overdose. So I don't really feel that MDMA is a great drug candidate to try to, oh, should we double the dose to try to get past this resistance? Because you could end up with some kind of stimulant toxicity. And there's that CYP2D6 interaction, which you're going to really increase blood concentrations of MDMA. So these drug-drug interaction trials, I mean, they're using small therapeutic doses of these types of things. Whereas if you're talking about, well, what happens in the club setting when, I don't know, one person on an antidepressant takes MDMA with their friends, and an hour later, their friends are having their MDMA experience and nothing's happening for them. And then they take another one, and 30 minutes later, nothing happening. They take another one, and all of a sudden, something adverse happens. So I don't like the strategy or idea with MDMA very much at all, because I think the data is stronger that there is a drug interaction. It's a more dangerous drug overall. And the interactions that we know about suggest increased blood concentrations. Whereas psilocybin, it seems probably more reasonable to sort of think about dose adjustments to try to overcome resistance, because there seems less ability for direct drug interaction in general, and psilocybin is just a much physically safer substance in large doses.
All right, thank you. Well, we're at time here, and we're going to write a summary of this, and I might ask you to clarify some questions. This is one of the most important safety topics with psychedelics. So I thank you so much for this wealth of information. And everyone, please go check out thespiritpharmacist.com, and you can schedule appointments and talk to Ben one-on-one. So I wish you all a wonderful weekend. Thanks for being here. Take care.
Thank you so much.